Okay. So Dr. Faiz and Dr. Sadia, can you see the screen properly now?
Yes, I can see it.
Okay. So welcome to today's Pathology Practice Mock 1 by MRCS Insights.
My pleasure.
Okay. So before starting, let's have some overview about pathology. There will be 2 stations in OSCE. We already all know that. So one station will be about surgical pathology and another station will be about surgical pathology or microbiology. And there will be one examiner in each station, and the marking is will be done on your clinical knowledge and research application only. And the total mark is 20. Okay. Okay.
Okay.
So you will get 1 minute to read the stem outside the station, and after hearing a bell you have to go to the station, and question answer session will be for another 9 minutes. Next. So okay, so Dr. Sadia,
Okay.
I'm going
Yes, I'm here.
on the timer. Okay, so read the stem for 1 minute.
Okay.
And question answer session will be next 9 minutes. Okay.
Should I read it aloud?
Yes.
A
Yes.
young Indian lady recently came back after a foreign travel, a cervical lymphadenopathy, night sweats, and weight loss. On examination, lymphadenopathy was found in the anterior triangle of the neck.
Okay. You have 25 seconds to think. Okay, let's start. Can you say what are the DD of this scenario?
Okay, it could be Hodgkin's lymphoma because the patient has cervical lymphadenopathy, and it could be tuberculosis and lymphadenitis and infectious mononucleosis.
Okay, very good. So in which labs you will send her sputum to?
I would like to send it for microbiology, for culture and sensitivity test, and for cytology labs.
Very good. And what are the tests you will do to confirm the disease?
Okay, so it is divided between active TB and latent TB. So for active TB, I would order for sputum examination and culture test with the Zeal-Nelson stain, acid-fast bacilli test. And for latent TB, I would order for Mantox tuberculin skin test. And there is a quantiferin interferon gamma test, and there is PCR that helps to differentiate between various species of TB. And for lymphadenopathy, there is fine needle aspiration cytology.
Very good. Okay. So next question is, which type of hypersensitivity is this meant to test?
Type 4.
Very good. And how will you label the sputum specimen?
I would label it as a category B. UN 3373 is the number.
Very good. And can you tell me the organism which is responsible for tuberculosis?
It's Mycobacterium tuberculosis.
Okay. And what other mycobacteria you know?
It's Mycobacterium avium intercellular for immunocompromised patients. And there is Mycobacterium bovis. There is Mycobacterium marinium and Kansasi and ulcerans and fortutium and Mycobacterium, and that's all these.
Okay. You told all the spaces. Very good. And what are the culture media used for diagnosing Mycobacterium tuberculosis?
There are basically two media. One is for solid media, and this contains of Livingston-Jensen's media and
Okay,
Middlebrook media and
okay,
Agawa media. And for liquid media, there is Bactec and Mycobacterium growth indicator tube.
very good. And how long to culture?
It takes around 1 to 8 weeks.
Very good. And what type of protein deposition occur in tuberculosis?
It's amyloid associated protein.
Very good. Would you please tell me what are giant cells?
Giant cells is a multinucleated macrophage along with epithelioid histiocytes, and it's basically a horseshoe shape, and it's present at peripheral nucleus at one pole.
Okay. Can you give me an example?
For giant cells,
Yes, giant cells. Which type of giant cells is found in case of tuberculosis?
it's Langerhans type giant cell, I think. Langerhans.
Langhans types of giant cell. Okay.
Langhans. Okay.
Yes. So what will you do in case of public health concerns in case of tuberculosis?
So I would notify consultant of communicable disease control center, and for patients advice is like that to avoid working in food factory and to wear a mask while coughing and sneezing,
Okay.
and to take anti-tuberculosis drugs and direct observed therapy.
Yes. And what is contact tracing?
Contact tracing is basically to diagnose a person and to identify a person who may have in contact with another infected person.
Very good. And what is your advice to the contacts?
So it could be starting from screening and counseling
Yes.
and treatment of friends and family of the infected person.
Very good. And what is granuloma?
Granuloma is basically aggregation or collection of macrophages along with the histiocytes, and in response to this basically in response to chronic inflammation.
Very
And
good.
this helps to identify any foreign particle to be eliminated from the system.
Okay, give me some examples of granuloma.
Okay, it's leprosy, rheumatoid arthritis,
Okay.
and one is the tuberculosis and Crohn's disease and sarcoidosis.
Another one?
And the leprosy, fungal infection.
Okay.
Schistosomiasis.
Okay, very good. That's all. You have completed within time. Thank you so much, Dr. Sadia. You have explained nicely, especially, the test parts. What are the tests?
Okay, thank you so much.
Excellent.
Okay,
So
thank you.
let's see. Actually, this was the station in my exam in Malaysia, Kuala Lumpur, and this tuberculosis station is very important in our Indian subcontinent, like Kolkata centers and also Malaysia and others, Pakistan. So invariably this topics will come in exam. Okay, and I almost forget to tell the cause leprosy in my exam and sarcoidosis because of nervousness. So I came to a mnemonic for this. So see what are the causes of granuloma. You can remember it by class, simply by a class. C means Crohn's disease, L leprosy, A arthritis, which is rheumatoid arthritis, S for sarcoidosis, and S for schistosomiasis. That's all.
Okay, great.
Okay. So next station. Let's see who raised hand. Dr. Fayaj.
Yes, ma'am.
Okay, Dr. Fayaj. Let me open the screen for you. Okay. Okay, Fayaj, read the stem loudly.
The patient presented in extension emergency department with hematemesis.
Yeah.
On OGD, peptic ulcer was found and biopsy was taken. Blood investigation showed hypercalcemia. Patient presented in hematemesis. Okay, peptic ulcer was found, biopsy was taken. Blood investigation showed hypercalcemia. Okay.
Okay. So can we start?
Yeah, we'll start.
Okay, so would you please define what is ulcer?
Ulcer is a discontinuation of the skin or epithelium or mucous membrane due to sloughing of necrotic tissue. Often it will associated with pus formation.
Okay. Often pus formation, are you sure?
Okay.
Not often pus formation. Okay. So would
Okay.
you tell me what are the risk factors of it?
Risk factors mainly H. pylori infection,
Yes.
in non-steroidal anti-inflammatory drugs and steroids,
Very good.
and stress condition,
Okay.
and smoking, alcohol, Zolling-Hanson's syndrome, and hypercalcemia.
Very good.
That's all.
Okay. So what is Helicobacter pylori? What type of
Helicobacter
bacteria
pylori,
it is?
it is gram negative, sorry, gram
Yes.
negative rod-shaped bacteria, which is non-motile and non-spore forming. And
Okay.
it's a helical shape.
A spiral shape. Okay.
Spiral shape, sorry.
Mm,
Spiral shape.
okay. So would you please tell me how it can survive in acidic media?
It will produce urease enzyme,
Very good.
by which it will continue the surviving medium into alkaline and reducing the acidic pH, and it also having a flagella, so it can move away from the acidic medium. It is also producing, it is attached to the foveolar cells and increase production of mucin, thereby neutralize the pH. Those are
Oh,
the factors.
okay. So what is CLO test?
CLO test is a Campylobacter-like organism test, in which we are taking sample by doing upper GI endoscopy, and put the sample in a medium which contain uh, urea, so that if the specimen is containing H. pylori, it will produce urease enzyme. It will convert the urea into ammonia. So in the medium we will be adding some indicator, phenol red, so it will change the color of the indicator from yellow to red.
Okay.
That is the Campylobacter-like organism test.
Okay, very good. And which mechanisms will help to, Helicobacter pylori to colonize in the stomach?
In the stomach mechanism, it will produce urease enzyme,
Okay.
and it will convert the urea into ammonia, and neutralize the pH of the stomach, and
Okay.
also which is having flagella, so it
Yes.
can swim away from the acidic medium. And also there are cells called foveolar cells in the stomach,
Okay.
so it will attach to the foveolar cells and enhance production of the mucin and water, so it will somewhat neutralizing the pH. That's
Is
all
there
I can
any
do.
other factor?
I can't remember.
Okay, no problem.
Mm.
So what type of gastric cancer that can be caused by this Helicobacter pylori?
Cancer, adenocarcinoma,
Do you know another one?
malt, mucosa associated tumor,
Yes. And
malt
what
tumor,
type of immune endocrine disease it may cause?
endocrine diseases, autoimmune thyroiditis,
Yes.
thyroid, uh,
What is it called?
Hashimoto's thyroiditis.
Very good. And how will you eradicate this Helicobacter pylori infection?
Can give PPI full dose with 20 milligram BD and for 1 week duration. With that, we can give clarithromycin 500 milligram BD dose and amoxicillin 1 gram BD. If the patient is an allergy to the penicillin, we can replace amoxicillin to flagyl 400 milligram BD with clarithromycin 250 milligram BD.
Okay. Have you told Flagyl?
Metronidazole, sorry, metronidazole.
Yes, that's a trade name. Okay.
Yeah.
You have to tell the generic name.
Yeah, okay.
Okay. So what is the mechanism of proton pump inhibitor?
Proton pump inhibitor, they will irreversibly inhibit the parietal. There's a receptor in the parietal cell, H plus K plus ATPase, which will bind to that receptor and irreversibly inhibit, thereby producing inhibiting the secretion of H plus into the lumen. So a reduction of HCl
Okay,
secretion.
don't say H plus. Okay, till hydrogen ion.
Hydrogen ion, okay.
Okay. And what are the actions of hydrochloric acid?
Hydrochloric acid, it is inhibit microorganisms and convert the pepsinogen into pepsine
Okay.
and help in reabsorption of the iron and calcium.
Yes.
Pepsinogen and calcium and inhibit microorganisms. That's all I can remember.
Okay. Does it stimulate secretion of any hormones from intestine?
Yeah, it will stimulate cholecystokinin secreting
Very good.
secretion.
Very good. How NSAID can cause peptic ulcer?
NSAID is topical irritant, direct topical irritant effect to the gastric mucosa, and also it will impair the barrier properties of the gastric mucosa. It is inhibit the COX-2 enzyme, thereby reduce production of the prostaglandin E2. So reduce vasodilation, reduce blood supply to the gastric mucosa. That superficial ulceration will impair healing of the superficial ulceration of the gastric mucosa.
Okay. Okay. So how many platelet present in packed RBC?
There is no platelet.
Yes. Actually, there is no platelet in packed RBC. So, okay. Would you please tell me the other causes of hematemesis in this patient?
Okay, this patient, the causes, one is peptic ulcer disease, the one is
Okay, see the stem again.
esophageal.
What the patient have?
Yeah, hypercalcemia.
Very good. So how hypercalcemia causes hematemesis in this patient?
Hypercalcemia will induce the parietal cells to secrete increased amount of hydrochloric acid, which will cause peptic ulcer disease.
Okay, but how? Does it stimulate any hormone secretion from stomach?
It is stimulate the G cells and
Yes.
gastrin secretion.
Very good.
Gastrin thereby stimulate the parietal cells to
Very
increase secretion of hydrochloric acid.
Very good. So, what are the common causes of hypercalcemia?
Common causes of hypercalcemia: malignancy, hyperparathyroidism,
Okay.
increased intake of calcium.
Another one?
Renal failure.
Yes. How to localize parathyroid gland?
Intraoperatively by fresh frozen plasma.
What?
Fresh frozen section. And pre-operatively, we can do system AB scan. If it is intraoperative, we can do
frozen section. You have already told that.
Frozen section.
Okay.
Post-operatively, we can check the parath hormone.
Okay. So this patient, had urinary tract infection. So what will be the cause?
This is due to formation of renal stone due to hypercalcemia.
Okay. Okay. Very good. Now tell me, What is frozen section?
Frozen section is a pathological test. It's done during the intraoperatively. We are taking serial samples of biopsies to exclude the to see the margin, and we are taking until a margin become free.
Okay.
That is called frozen section.
Okay. So how the specimen is fixed?
The specimen is initially placed in a metallic disc and
Okay.
frozen into -20 to -30 degrees.
Okay.
After that, it is embedded in alcohol. After that,
Alcohol. Okay. Which is the name of the medium?
I can't remember.
Okay, no
Actually.
problem. Carry on.
Okay. After that, it will cut with the microtome portion of the cryostat and
Yes.
put in the with we'll see under the microscope with HNE stain.
Okay.
Hemotoxicillin and
What
eosin.
stands for? Yes, right. So why we can't use paraffin in case of frozen section?
It will take longer time to stain.
Embedded through tissue. Okay.
Okay.
So
Okay.
would you please tell me the epithelial lining of gastric antral mucosa?
This is contains columnar cells with goblet. Simple columnar epithelium with goblet cells.
Very good. Very good. Now see, read the stem. After removal of 4 parathyroid gland, you are given this report. Okay, 1 gland containing 0.3 gram of chip cells and 3 glands containing 0.08 to 0.09 gram of oxyphilic cell and some fat cells. So what is your interpretation?
Histology containing chief cell and oxyphil cell.
Yes.
Parathyroid adenoma or hyperplasia.
Parathyroid adenoma in how many glands?
Removal of 4 gland, you are given this report 1 gland, 0.3 gram, chief cell, 3 glands.
Where is much more chip cell?
Chief cell, you are given this report 1 gland, 0.2 gram. I didn't understand this question.
Okay, okay. Would you please tell me histology of parathyroid adenoma?
I'll come back this later.
Okay. So what are the types of hyperthyroidism?
Parathyroidism, primary, secondary, and tertiary.
Can you give me a single example of it?
Primary hyperparathyroidism due to parathyroid adenoma, secondary due to secondary renal failure, and tertiary is due to renal transplant, gland becoming autonomous.
Okay. What is the treatment of hypercalcemia?
Hypercalcemia, we have to hydrate the patient, and we attach to cardiac monitor to hydrate the patient. We have to manage according to the care of critical ill surgical patient protocol, hydrate the patient and attach to cardiac monitor, and also we have to give IV calcitonin, and we can start bisphosphonates, pamitonate like.
Okay. And any other drugs, IV drugs for forced diuresis?
IV Lasix, IV furosemide.
Very good, IV furosemide. So if parathyroid gland is not found in normal position, where will you search for it?
The with thymus in the mediastinum.
Are you sure? In which mediastinum?
And superior mediastinum.
Yes, superior mediastinum. And what is the treatment option for parathyroid adenoma?
Parathyroid adenoma, excision of the gland, parathyroid gland.
Okay. Thank you very much, Dr. Fayaz. Actually, this station is contains huge questions, 21 questions. You will not get this much questions. I have added all the questions. Okay. So from these 21 questions, you will get, 10 or 11 questions in your exam.
Yeah.
Okay, very good, Dr. Fayaz. You almost answer every questions. 1 or 2 questions you missed, but that will be no problem at all. Okay. Very good,
What
Dr.
is the
Files.
what is the answer for that, madam? Question number 19.
Yes, yes, I will tell you. So after removal of 4 parathyroid gland, you were given this report, which containing that one gland having 0.3 gram of chip cells and the other 3 glands containing very little amount, which is 0.08 to 0.09 gram of oxyphil cell and fat cell. Okay, that indicates that one gland containing parathyroid adenoma, and the
Okay.
other three with involution of parathyroid adenoma. Okay, as
Okay.
you can see that there is very little amount of oxyphil cell in rest 3 glands. Okay,
Mhm.
and histology of parathyroid adenoma, I am going to share the slide. Okay.
Okay.
Okay, so in this question, mechanism of colonization of Helicobacter pylori in stomach, you forgot to tell about adhesins and toxins. Okay, so if you remember this FUAT, you you don't miss in the exam to tell all the mechanism. Okay, so what stands
Okay.
for a flagella, which maintains motility in viscous mucus. Okay, and U for urease,
Okay.
we already know that it breaks the urea to ammonia and make the alkaline environment. Next, A for adhesins, which attach the bacteria with the gastric foveolar cell, and T for toxins. Okay, these toxins is responsible for development of ulcer or even cancer in this peptic ulcer diseased patient. Okay.
Okay.
So next slide, you have told nicely what is CLO test. Here we can see that in this test, there will be a media which will contain urea, and there will be an indicator which is phenol rate. Normally in acidic or normal, it will be yellow in color. And in alkaline media, it will be red, and the specimen contains urease enzyme. So what is the reaction if we place a sample which is obtained through gastroscopy, and then we place the specimen in this media containing urea? What will happen? The urease, which is produced by Helicobacter pylori, hydrolyzes the urea into ammonia, and which will increase the pH of the media and make the environment alkaline. Okay, so if we put a indicator in this media, it will turn into red, and which indicates
Red color.
that it is positive reaction for Helicobacter pylori. Okay, and frozen section,
Okay.
just a little introduction. It's a pathological laboratory procedure which is used for rapid microscopic analysis for specimen. And how it is done? See, specimen placed on a metal disc and rapidly frozen into -20 to 30 degrees Celsius. Then it will be embedded in a gel-like media, which name is OCT, contains polyphenol alcohol and polyethylene glycol. Okay. And after that, it is cut frozen by microtome portion of cryostat. And after that, a section is put on a glass slide and stained with hematoxylin and diosine. And after that, it is seen under microscope. Okay. Okay. So this is the tough question of this topic, I think, histology of parathyroid adenoma. At first, please see the normal parathyroid gland histology. This is a parathyroid gland, a slide of histological picture of parathyroid gland. It contains 2 types of cell. Okay, mainly chip cells, and these islets are called oxyphil cells. Okay, and there is see many chip cells and little oxyphil cells, which are separated from each other by fibrous septa. See. Okay, connective tissue septa or fibrous septa. See, so what will be happen in case of adenoma? This uniform polygonal chip cell and centrally placed small nuclei. Okay, so parathyroid adenoma will contain what? Uniform polygonal chip cells and centrally placed small nuclei. And also there will be a nests of large oxyphil cells. See, few nests of oxyphil cell. Uncommonly, most of the adenoma are composed of this type of which cell? Oxyphil cell. And also there will be a rim of non-neoplastic parathyroid tissue around the parathyroid adenoma, which will be separated by fibrous rim. Okay, this is the histology of parathyroid adenoma. So who will be the next? Dr. Faiz, clear?
Yes, madam, clear.
Okay, very
Very
good.
clear. Thank you.
Okay. Okay. So let's see who join us. Dr. Shumona, Dr. Shaun Choudhury, Dr. Pooja, Munia Tamanna, Dr. Sharmin Ahmed, Dr. Ridoy, Dr. Shoili, Dr. Orpita Shaha, Dr. Enamul Haq, Dr. Ahmad Abdalaziz. Okay, who will be the next? Please raise your hand.
I can take this one if you are asking to someone to who
Okay,
is
no
willing to.
problem. No problem, Dr. Ahmad. You can continue.
Okay, I'm happy to start.
Okay, read the stem.
Okay.
Dr. Ahmad, read the stem loudly, okay?
Okay, ma'am.
Please start.
Okay. A 60-year-old lady presented with headache, skull tenderness, and mastication, as well as transient loss of vision. Biopsy from temporal artery revealed giant cell arteritis.
Okay.
Granulomas with okay. First question: what is giant cell arteritis? Giant cell arteritis is a inflammatory granulomatous inflammation that affect medium and large sized arteries, especially the branches of the external carotid arteries.
Okay. Which part of the vessel affected most?
The media.
Tunica media. Yes, very good. Would you please describe the pathological changes in microscopic picture?
Internal disruption of the internal aesthetic lamina with
Yes.
granulomatous inflammation,
Okay.
showing infiltration of giant cells, macrophage, fibroblasts, and lymphocytes, T lymphocytes.
Any other change?
Thickening of the arterial wall, I guess.
Which layer?
It's all the layers, but especially the intima tunica media.
Are you sure? Tunica media. Thickening of which part? Can you be specific?
No, I have no idea.
Okay, no problem. So now tell me one simple blood test to prove that the patient has giant cell arteritis.
ESR. ESR.
Okay, what will be ESR?
Yes.
Will
Sorry,
be
I dropped
will be it elevated or decreased level?
elevated ESR. Yes.
Yes, elevated ESR. You have to tell full sentence. Okay.
Okay.
Now tell me most confirmatory test of giant cell arteritis.
Of course, a biopsy of the affected vessel.
Which artery?
The affected vessel, but it's most commonly affect the superficial temporal artery.
Very good. And now tell me why this patient is having transient blindness.
Why this may cause transient? Okay, maybe because of the affection of the ophthalmic artery, which gives the central retinal artery, which is an end artery, causing brightness.
Very good, very good. Can you tell me the treatment of this blindness?
Once the patient has a blindness, we should commence with methylprednisolone, 60 milligram per day for 2 years.
Okay. Now come to the next question. 1 year later, the patient have developed fracture neck of femur. Why?
She is most probably having osteoporosis.
Another cause?
Another cause.
because of the steroid?
Yes. Osteoporosis is secondary to its steroid and post menopause.
Uh, not menopause. Okay, no problem. We'll come back later on this
She
question.
is 60-year-old. Yes.
Okay, so why osteoporosis in this patient?
Um, for 3 factors. She is female. She is old, and she post-menopause, and she is on long-acting steroids.
Very good. Very good.
Yes.
So what will be the pathological changes in case of osteoporosis?
Okay. In osteoporosis, there is preserved bone architecture with decreased density and normal mineralization.
Okay. Any other pathological changes?
Mm, um, microfractures, or what are you looking for exactly?
Okay. Okay. So what is osteoporosis?
What is osteoporosis and what is okay? Okay, osteoporosis is a metabolic bone disease
Hmm.
that occurs through many factors like steroids, old age, hormone replacement therapy. In
Okay.
this osteoporosis, there is overactivity of osteoclast, and with osteoblasts being less active.
Okay. Can you tell me the pathogenesis?
Corticosteroid. Okay, the pathogenesis. Okay, of the corticosteroid exactly causing the osteoporosis. Yes.
Okay, no problem. How corticosteroid causes osteoporosis?
It inhibits the osteoblast.
Okay. What? Can you tell me clearly?
Sorry.
What is the how corticosteroid causes osteoporosis? Can you tell me the causes?
I really can't recall this, but I
No
think it's
problem. You
Rankel ligand, which is I really cannot recall this.
okay,
Sorry.
no problem. Tell the examiner that may I come back later to this question, please.
Okay.
Okay. Try to practice this. Okay.
Okay.
So what are the
Okay.
causes of osteoporosis?
In general, steroids, as we mentioned, post menopause, uh, um, uh, osteoporosis, not pathological fractures, huh? Okay, like just this. Osteoporosis, hyperparathyroidism, chronic kidney disease, I guess.
Can you tell me some gastrointestinal cause?
Of course, maybe malabsorption syndrome, Crohn's disease, what else? Vitamin D deficiency, cholestatic liver disease, maybe.
Okay. Okay,
Yeah.
no problem. So I'm going to stop the timer for you.
Okay.
Okay. So Dr. Ahmad, very good. You have to practice more. Okay. You
Of
have
course, yes. Okay.
yes. You recall it nicely, but if you practice more, then it will be more clear. Okay.
Okay. Okay.
Okay. So who will be next? Will you want to continue the next 10 question?
Okay.
Okay, no problem. No problem. Carry on. So will be the other causes of pathological fracture?
Okay. Other cause of budget disease, osteomalacia,
Yes.
primary bone neoplasm, multiple myeloma, and secondaries to the bone, and hyperparathyroidism and chronic kidney disease.
Okay. Is there any other causes?
Uh, No, I don't.
Actually, the
recall.
examiner will not let you go until you tell all the causes. Okay, that's why I repeatedly ask you what are the causes. No problem. Okay,
Mm.
so what is multiple myeloma?
Multiple myeloma is a malignant neoplasm that affect plasma cells. It's characterized by increased Benz-Johnson proteins
Okay,
in urine acid, as well as osteolytic and characterized by osteolytic lesions.
yes.
Yes.
Okay, so how will you diagnose this patient?
According to the CRAB criteria. CRAB
Uh,
criteria is hypercalcemia,
yes,
renal failure, amyloid protein deposition. B is Benz-Johnson protein.
A for anemia. Okay,
A for anemia.
yes.
Yes, sorry about this.
Yes. Okay. So what will you get on his, protein electrophoresis?
Yeah. Sorry, what's the next question?
Okay.
This.
What will be the finding on protein electrophoresis?
Amyloid light chain.
Yes, M spike protein. Okay.
Okay, M spike
Okay.
protein.
Yes, yes. So what is Benz-Jones protein?
I think Miss Benz Jones protein is a microglobulin made by the plasma cells.
Immunoglobulin.
Yes, immunoglobulin made by the plasma cells. Yes.
Very good. Okay. So the patient is on steroid. Now the patient need to undergo a sudden surgery. What will happen?
There are a lot of concerns since the patient is on steroid. He may have diabetes and hypertension due to salt and water retention. Post-operative, he may have a delayed wound healing and delayed recovery. And the main concern would be Addisonian crisis.
Very good. Addisonian's crisis. How to prevent it?
If the patient is receiving more than 5 milligram cortisone, hydrocortisone, he would receive 100 milligram at the induction with 20 milligram post-operative.
Are you
With,
sure?
with 20 milligram, yes.
Okay. And what next?
Post-operatively, if he is tolerating feeding, he will receive 20 milligram in the next post-operative day. But once he tolerates feeding, he will continue in the double of the oral dose.
Okay. Do you need to increase the steroid dose prior surgery?
He is at the time of the induction, not
Okay. Only
yes,
induction? Only induction?
yes, induction at and post-operative.
Okay. So the patient went total hip replacement and died on post-operative day 1. What happened?
Maybe by fat embolism.
Yes. And what are the causes of fat embolism? Just tell me 5 causes.
Okay. Maybe long bone fractures, pancreatitis, long bone fracture, pancreatitis. Just this, I cannot recall.
Oh, okay, no problem. So how to prevent this fat embolism?
How to prevent this fat embolism? Okay, I would like to pause this question.
Okay. So can you tell me what is ESR?
ESR is a blood technique that measure the time when. Sorry, I cannot record this at all.
Okay, no problem.
Yes.
Does anyone want to answer these questions, these three questions? What is ESR? And how to measure the ESR?
Yes, I can. I can explain the ACR. ACR is when blood is taken, put in the test tube and anticoagulate
Yes,
and
very good.
an anticoagulation. Then
Okay,
it left and observed after 1 hour and 2 hours.
1 hour. Okay, very good. And what is the pathogenesis of osteomalacia?
Osteomalacia is it's a mineral bone disease where there is decreased minerals and there is decreased in bone mineralization, I guess. Pathogenesis when there is hyperparathyroidism or in one
No,
of the causes.
hyperparathyroidism is not related with osteomalacia. Okay, no problem. We'll see. Okay, so what are the causes of postmenopausal osteoporosis?
Mm, I can't recall this at all. Sorry.
Okay, no problem. You are doing great. No problem. Just practice more. Okay.
Yes, I need to read this station once again.
Okay, no problem. So let's see. Okay. This
Okay.
was our giant cell arteritis or temporal arteritis station. This is very important. Okay. So let's see the microscopic picture of giant cell arteritis. What you missed. Okay. Let's see. This is a normal artery. Okay. And we all know that the artery has three parts. In the periphery, it contains tunica externa. In the middle part, tunica media, which is more commonly involved in case of giant cell arteritis. And the internal portion is tunica intima. And in between tunica intima and media, there is a layer which is called internal elastic lamina. And in between tunica externa and media, there is external elastic lamina. These 5 layers contains an arterial wall. Okay. And what will happen
Yes.
in case of giant cell arteritis? What changes will occur in these layers? Let's see. At first, what will happen in tunica intima? There will be tunica intimal thickening, and that's why there will be narrowing of the lumen. See this? Okay. So what will happen in case of tunica media? See, there is aggregation of granulomatous inflammation, and also there will be infiltration of T cell. Okay, and CD4 T cell will be more than CD8 T cell, and also there will be macrophages. Okay, so what is the next layer? See, internal elastic lamina. And what will happen in case of internal elastic lamina? See this, there is fragmentation of internal elastic lamina. So remember these 3 pathogenesis of giant cell arteritis. Okay, so at first there will be in tunica intimal thickening, then medial granulomatous inflammation, and there will be fragmentation of internal elastic lamina. And these multinucleated giant cells will found only approximately 85% of specimen. Okay. And the inflammatory relations are focally distributed. Like here is some inflammation, and there is some normal portion, and again there will be some inflammation. Okay. This is the microscopic picture of giant cell arteritis. Next, what is osteoporosis? You have told the definition, pathogenesis, okay, but try to, tell the examiners more specifically, okay? So what is osteoporosis? It's a type of metabolic bone disease. See, what will happen here? There will be low bone mass, low bone matrix, so there will be increased fragility. And for these 3 regions, there will be microarchitectural deterioration. Okay. So pathogenesis is very simple. There will be increased bone resorption because of increased osteoclastic activity, and there will be inadequate new bone formation because of decreased osteoblastic activity. So what will be the result? Inadequate peak bone mass. Okay, try to remember like this. Now come to the pathological changes in osteoporosis. See, in case of osteoporosis, there will be histologically normal bone, but just decrease in quantity. Okay, and in postmenopausal women like this patient, there will be increased osteoclastic activity. and this will affect the bones that having increased surface area, like cancellous part of the vertebral body. And you can see here the trabeculae. Okay, these are the bone cell, osteocyte. And we all know that the osteocytes are connected with each other by these trabeculae. Okay, see. So what will happen in case of osteoporosis? These trabeculae will lose their connection. So they will be thinned, perforated, and also there will be micro fracture and there will be vertebral collapse. This is the pathological change in osteoporosis. Next. What are the pathological causes of pathological fracture? Okay, there are 6 causes and you have to tell all the 6 causes. So try to remember like this, that the patient has already multiple myeloma, and then multiple myeloma, what happened? Skeletal metastasis. And for the skeletal metastasis, you give the patient radiotherapy. So we get here 3 causes. One is multiple myeloma, second one is skeletal metastasis, and the third one is radiotherapy. Okay, so remember the 2 causes by remembering the vitamin D deficiency. In case of child, there will be rickets, and in case of adult, there will be osteomalacia. So these 2 will cause pathological fracture. And there are another 2 causes which make the bone vulnerable. One is osteogenesis imperfecta, and another one is Paget's disease. Okay, Dr. Ahmad?
Yes, that's very informative. Thank you.
Okay, very good. And multiple myeloma, you have told nicely that it's a plasma cell neoplasm, which is characterized by lytic bone lesion, renal failure, hypercalcemia, and immune abnormalities. And it is the most common primary bone tumor in case of elderly. Okay. Now, how we diagnose the multiple myeloma? You have told the CRAB features, and also in case of some investigations, like in X-ray, you will find lytic bone lesions in skull, and in protein electrophoresis, there will be a spike protein, and in urine, you will get Benz-Jones protein. And this Benz-Jones protein will, will be found in 2/3 of the case of multiple myeloma. Okay. Okay, so prevention of Addisonian's crisis. See, at first you have to tell this, like in case of patient who are on steroid, if they are undergoing in any urgent surgery. So what we should do, increase the patient's steroid dose before surgery and also convert the oral into IV one. Okay, and I just add the doses of steroid here for better understand. Okay, I think you all know this chart. Okay, so just
Isn't
yes.
5 milligram, not 10, I guess. The new, there's new guideline states that
Okay.
if it's 5 milligram, not 10.
5 milligram. Okay, okay. I will check and definitely let you know. Okay, so if the patient is on a steroid and let's say 5 or 10 milligram per day, less than, okay. So assume that he has normal hypothalamic pituitary axis. So he just get the usual doses, okay. And if he is on more than 5 or 10 milligram per day, then in case of minor surgery, just usual dose and 25 milligram IV hydrocortisone just at induction. And in case of moderate surgery, just these 2 and add 100 milligram per day for next 24 hours. And in case of major surgery, just same things. You have to just continue the 100 milligram per day IV hydrocortisone for next 2 to 3 days only. Okay. Okay. So let's see what is ESR. ESR, actually it measures how quickly the RBC settled down at the bottom of a test tube, which contains a blood sample. Okay, so in normal cases, the RBC settle down slowly, but if we can see that the RBC settle down faster than normal, which indicates there may be some inflammation within the body. And how it will measure? By Westergren Tape's method. It's a method containing a tube which is marked up to 200 millimeter. Okay, and we have to draw the blood up to this 20 millimeter of marking. And then the tube is kept vertically for 1 hour, and after 1 hour we have to measure the distance between top of the blood and top of the sediment. See, suppose this is a western green tube, 200 millimeter marking, and after 1 hour the RBC settle down here. So this distance, okay, from top of the blood to the top of the sediment, this distance is the measurement of ESR. Okay. So osteomalacia, now come to the topic osteomalacia. What is it? It is just deficient bone mineralization, but the bone matrix will be normal. Okay. And the last question was postmenopausal osteoporosis. What are the reasons? In case of postmenopausal women, there will be deficient estrogen. And as a result, there will be raised follicle stimulating hormone. What will happen? These two, increase follicle stimulating hormone and decrease level of estrogen, will stimulate the osteoclastic bone resorption, and that is why postmenopausal lady easily get osteoporosis. Okay, is it clear for all?
Yes, yes, it's very clear.
Okay, so who will be the next? Please unmute yourself and tell yes. Who want to participate? No problem, participate. What you can just tell.
I can participate if no one is willing. I think I am recalling this one very well.
Okay. Okay. So does anyone other than Dr. Ahmad want to tell? Last chance, last call. I see.
Okay, I can take it.
Who was that?
Dr. Orpita.
Okay, Dr. Ahmad, would you mind
Dr.
if Dr. Ahmad, would you mind if I Dr. Orpita Shah, right?
Of course. I just I thought no one is willing to take the station. It's totally fine.
Okay, thank you so much, Dr. Ahmad, for your cooperation. So, Dr. Orpita Shah, are you there?
Yes,
Okay, okay. So, please read the stem loudly for me.
okay. So, as a patient waiting for an operation having aortic stenosis.
Okay. Let's start, Dr. Orpita.
Okay.
Okay, so what are the clinical pictures of aortic stenosis?
Okay, so in the mild cases, the patient will be asymptomatic. In moderate to severe cases, there will be a triad that includes dyspnea, syncope, and there was another syncope, dyspnea, and forgot another one.
Okay, what are the signs you will get in case of a patient having aortic stenosis?
What are the signs?
Yes.
Angina.
Signs means what will happen in case of pulse.
Pulsus alternans.
Very good. Is there any change in case of pulse pressure?
A narrow pulse pressure.
Very good. Very good. And do you get any murmur?
Ejection systolic murmur.
That's great. And which side you will get the murmur?
In which side? As in on the precordial area.
Can you be more specific, like which intercostal space?
Okay, so aorta is the right second intercostal.
Very good, Dr. Orpita. Excellent. So what are the causes of aortic stenosis?
So first there is lipid accumulation that causes so after there is inflammation, there is lipid accumulation that causes calcification and further on stenosis.
Okay, you just told the pathophysiology of aortic stenosis. Okay, so what are the causes of aortic stenosis? I will take the answer for pathophysiology. Okay, no problem. So now tell me the causes of aortic stenosis. What are the cause? Any causes which involve, child, adult, or elderly like this?
Yes. In young patients, there may be congenital deformed valve. In case
Yes.
of patients, senile calcific aortic stenosis and post-traumatic heart disease scarring, valve scarring.
Okay. Okay, very good. So now tell me, what are the causes of sudden death in case of aortic stenosis?
Sudden death would be due to MI and aortic dissection.
Okay, very good. Dr. Ahmad, please do not send the messages, okay? Just participate. Okay, very good. So how stenosis occurs?
Okay, so from the sclerosis to stenosis, there is a left ventricular hypertrophy that leads to increased myocardial function and increased oxygen consumption and myocardial workload. Um,
Okay, another one.
Another one would be
Is there any pressure change in pulmonary vascular system?
yes, it may cause the retrograde blood flow into the due to regurgitation. It causes retrograde blood flow into the lung vasculature, causing pulmonary hypertension.
Okay, and also backflow of pressure. Okay.
Back blood pressure, yes.
Okay. Now the patient having aortic stenosis after a while get weakness in the arm. Why?
Due to a cerebrovascular attack.
Okay. By which mechanism?
Due to thromboembolism.
Very good. Which coagulation system is not affected by warfarin?
Extrinsic pathway.
Very good. Now tell me, what is thrombus?
Okay, so this is an healthy response to stop the bleeding, which is formed by the constituents of the blood in a flowing blood.
Very good. And what are the surgical options available for valve replacement?
There is surgical valve replacement, there is metallic valve, there is tissue valve, Ross procedure, there is transcatheter aortic valve replacement, and there is balloon valvoplasty.
Very good. Very good, Dr. Pita. Now tell me, after metallic valve replacement, the patient have developed infective endocarditis. So why the valve should be removed?
It should be removed because it will act as a septic foci and it will be dehiscent and the bacteria will form the biofilm, and even after the treatment it cannot cross the biofilm, so it should be replaced.
Very good. And now, if we found microscopic branching hyphae over the valve, what will be the differentials?
It could be a fungal infection.
Okay, what are the causative agents?
Okay, it could be with Candida, Aspergillus, Microsporum, Trichophyton, and Epidermophyton.
Very good. Can you tell me some differences between mechanical and tissue valve?
Mechanical tissue valve causes a machinery click, and tissue valves are basically noiseless. Mechanical lasts through 30 to 40 years. There is decreased chances of reoperation, but in case of tissue valve, there is increased chances of reoperation as it will last for about 5 to 10 years. For mechanical, warfarin is needed for lifelong, and for tissue valve, warfarin is needed only for the first 3 months. And in case of mechanical, there is increased bleeding risk, increased risks of thromboembolism. But in tissue valve, there is decreased bleeding risk and decreased occurrence of thromboembolism.
Very good. Okay. Now tell me why the patient having aortic stenosis are more susceptible to infective endocarditis.
Okay, so due to aortic stenosis, the blood cannot go smoothly over the valve. So there is that area acts as a good space for the colonization of the bacteria, causing infective endocarditis.
Very good. Can you tell me what is CRP?
This is a C-reactive protein, which is a byproduct of acute inflammation.
And how it is produced?
How it is produced, I can't recall the answer.
Which interleukin is responsible for this production?
No, I can't recall it.
Okay, no problem. Now tell me what would be the histopathological findings of removed valve? What will you find?
On a removed valve, okay.
Okay, no problem. If you don't remember the answer, just tell, may I come back later? Okay, no
Yeah.
problem.
Later, okay.
Okay, no problem. So after valve replacement, why the patient should be on warfarin?
Because there is increased risk of thromboembolism.
Yes, so to prevent that, the patient should be on warfarin.
Yes.
Now tell me, what surgery should be done in case of infected prostatic valve?
The prostatic valve should be removed.
Can you tell me more about it? In case of any infection, abscess, what will we do?
No, I have no idea.
Okay, no problem. No problem. We just remove the, infected tissue and draining the abscesses. Okay. And repair the, if there will be any fistulas, just repair the fistula. Okay.
Okay.
So what will be the answer? Like this. Just we have to debride the infected tissue, and if there is any pus or abscesses, just drain it and repair of any abnormalities like fistula. Okay, that's all. Very good, Dr. Orpita. You have done nicely this with the station. Okay. So
Thank
try
you.
to practice more. Have you booked your exam
Yes, I have in August.
in August? No problem. You will do better.
Thank you.
Okay. So let's see some confusing topics. Okay.
Okay.
See, aortic stenosis was our station, right? So what are the clinical pictures of aortic stenosis? We'll get some symptoms. Okay. What symptoms? Try to remember like this. In brain, there will be less blood supply. So what will happen? Syncopal attack, right? In case of heart, there will be less blood supply. So what will happen? Anginal pain. Okay. And in case of lung, there will be dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Okay. Try to remember these major organs and symptoms. You will never forget in your exam. And what will be the signs? In case of heart sound, there will be two abnormalities like paradoxical splitting of second heart sound, and we will get ejection systolic murmur in right second intercostal space. And in case of pulse, there will be two abnormalities. One is pulsus alternus and another one is narrow pulse pressure. Okay. So two findings with pulse and two findings with heart sound. Okay. So now come to the causes of aortic stenosis. There are three causes. We can divide it with age, like in case of less than 30 years of age, there will be congenital, and 30 to 70 years, they are rheumatic, and more than 70 years, they are degenerative. Okay. In case of rheumatic, there will be associated mitral valve disease, and in case of more than 70 years of patient, there will be association of diabetes mellitus and hypercholesterolemia. And what is the pathophysiology? See, in case of congenital, there will be either unicuspid, bicuspid, or abnormal tricuspid valve. So there will be abnormal flow, and eventually fibrosed and calcified. Okay. And in case of rheumatic, as we all know that there will be inflammation, adhesion, fibrosis, and calcification. That is very easy. And in case of degenerative, there will be calcium deposition at the base of valve. Okay. Now
Okay.
come to the pathophysiology of aortic stenosis. Okay, Dr. Orpita, listen carefully. Okay. So at first, we will start from here. Aortic stenosis. What will happen? As a result of aortic stenosis, the left ventricle have to encounter chronic resistance to systolic ejection. So there will be increased afterload. Okay, afterload means there will be increased peripheral vascular resistance. So as the left ventricle have to encounter chronic resistance, so what will change in its wall? There will be left ventricular hypertrophy. There will be thickening of ventricular muscle. Okay, so if there is increased muscle mass, there will be increased workload, and also there will be increased oxygen consumption. As a result, the left ventricular chamber will be small in size. So it will get less blood, so there will be decreased preload. Okay, so what will happen? It will cause more systolic dysfunction, and more systolic dysfunction means there will be less stroke volume. It's very simple, as there is less stroke volume, so there will be less cardiac output, and also there will be less ejection fraction. Okay, and also as the left ventricle have to encounter more pressure, there will be backflow of this pressure into the lung, which will cause pulmonary vasoconstriction, and as a result there will be pulmonary hypertension, and it will cause increased mortality. Okay, get it, Dr. Orpita?
Yes, I got it.
Okay, very good. Now I think you can tell it more easily.
Yes, yes.
So what will be the DD of fungal infection? We can easily remember it by CAMT. C for Candida, Aspergillus, A for, and M for Microsporum, T for Trichophyton, and E for Epidermophyton. And what is CRP? It's a acute phase protein which is produced by the liver and stimulated by interleukin. Dr. Urpita, interleukin 6. Okay, and released in response to any injury or inflammation in the body. Now come to the histopathological findings of removed valve. Very important. Okay, in acute cases there will be fresh vegetations, and what the vegetations will contain? It will contain platelet, fibrin, neutrophil, and colonization of microorganism. Okay, and in case of chronic case, what will happen? The vegetation shows organization. There will be some vascularity and eventually calcification, and also we will get some fibrosed thrombi in chronic cases. Okay, these are the pathological findings of removed valve. Okay, so we come to the last question. Now tell me who want to participate this session. Please unmute yourself. Who will be the next? Who want to be the next? I can see 13 doctors have joined us. Dr. Graceful, do you want to participate this session? Can you hear me? This is the last station. And very important station. I think he doesn't get me. Okay, Dr. Joy T, do you want to participate? Dr. Pooja Talreza, please raise your hand who want to participate. Dr. Shumona, Dr. Ryan, Dr. Pooja, Dr. Sharmin. Anyone wants to participate?
I can take this if no one wants to participate. But keep me as an alternative. If anyone wants to take the station, it's totally fine.
Okay, Dr. Ahmad. Okay. This is the last station. And you
I
guys
want to
already-
participate. But yeah, but if I'm confused in between, so can anyone help me?
Okay, no problem. Dr. Ahmad and Dr. Pooja. Okay.
Okay, that's fine.
Okay.
What
So first up,
the station or we will take question by question? I can understand.
okay, no problem. Dr. Ahmad and Pooja, this station contains, about 20 to 22 questions. So we can divide
Okay.
it into two. Okay. So first up,
Okay.
For Dr. Pooja and the second half for Dr. Ahmad.
Okay, that's fine.
Okay. Okay, nice. That's great. So Dr. Pooja, can you see the screen?
Yes.
Okay, so read the stem loud.
Mammogram and pathology report will be given.
What you can see here in this mammogram.
I can see there is a calcified lesion in one upper quadrant of the breast with that shows calcifications. A hyperdense shadow in the upper quadrant that shows calcifications, suggestive of calcifications.
Okay. So now tell me what other test to do.
I'll do finding the respiration cytology of this lesion.
Any other
And
tests?
also, I can do like if the patient had previous history of previous surgery, I can go for MRI, and of course some blood test, baseline blood test, and some tumor markers like I will send this SNSE tissue for receptors, immunohistochemistry, and for ER and PR receptors, and for HER2.
Okay, very good.
And also I'll look for spread, like in chest. I'll perform CT chest and look for a spread.
Very good. Now the FNAC report has raised and it showed that C4 lesion. What does it mean?
It means that it's suspicious of malignancy.
Yes, suspicious of malignancy. Now tell me, the FNAC sample is taken, but the pathologist can't report. Why?
Because SNSE is taken, it's a simple invasive, is a minimal invasive procedure where small tissue is taken. So it may, and the malignancy, for malignancy, the capsule should be involved. Like we should have, in FNSE, we cannot comment on if the capsule is involved or not. And because of the sample size, there can be inaccurate results in case of final respiration cytology.
Okay. So what is the most common type of, I think the capsule part is for thyroid malignancy. Okay.
Okay, so it's like its sample size would be minimum, so that can be a problem.
Okay. Okay. So what is the most common type of breast cancer?
It's invasive ductal carcinoma.
And what is the most common site?
Upper outer quadrant.
Very good. Now, after excision, what to look for in the pathology report?
So I'll look for the margins, whether they're involved or not, and what is the depth of lesion. And I'll also do its immunohistochemistry and look for whether they are ER or PR positive.
Any
And
other
lymphovascular
thing? Yes.
invasion, lymphovascular invasion.
Yes, very good. Okay, so one microscopic test to do before latissimus dorsi flap of this patient.
I think we'll do Culture and sensitivity.
To exclude
Culture and sensitivity. Whether there is infection or not.
what type of infection? Can you be more specific?
I don't know. I'm sorry.
Okay, no problem. Just tell that I will come back later. No problem.
Okay.
Okay. So what is HER2?
It's HER2 Herceptin 2 receptor. It's a receptor of tyrosine protein kinase family. It's involved in regulation of gene, like it increases the proliferation of cell.
Okay. Now tell me how to test for HER2.
For this, I think imatinib
How to test?
HER2
What are the investigations?
with for this immunohistochemistry is done. Like I think imatinib is given, and that binds with this receptor.
Okay, that is for, the treatment purpose. Okay. And the investigation for HER2, how we detect? Yes, one is immunohistochemistry. Another test,
No, I
Okay.
forgot.
Okay, no problem. It is fluorescent in situ hybridization. Okay, FISH.
Okay.
We can detect the HER2 receptor by two tests. One is immunohistochemistry and another one is FISH, which is fluorescent in situ hybridization. And what signifies if the HER2 become positive?
If HER, it tells the prognosis is worst. Like the tumor will be less sensitive to treatment, and it signifies the prognosis.
Okay. Okay. So what is Herceptin?
I don't know these questions.
Okay, Dr. Ahmad.
Forgot.
Dr. Ahmad,
Yeah, Dr. Ahmed can go for this.
Yes.
what is Herceptin?
Herceptin is a monoclonal antibody that target the cell overexpressing the gene HER2.
Very good. Very good.
Yeah.
Okay.
Thank you.
Can you tell me how it works?
Just mentioned it's monoclonal antibody that target the cells that overproduce the HER2 protein.
Okay. Okay.
Okay.
Okay. So, Dr. Pooja, can you tell me what else you will consider in management of this patient?
I'll involve oncology team. I'll discuss it in multidisciplinary team. I'll also involve a plastic surgeon because it needs a flap. And
Okay, I ask you the management options.
for tumor, it has after triple is mastectomy has been it's been taken out. I don't.
Okay,
So
that
after
is,
that, there are options of chemoradiotherapy.
yes, chemoradiotherapy
Yeah.
and also hormonal therapy. And now your question, who should be involved in care of this patient?
For this, I will involve oncology team, discuss it in multidisciplinary, and I'll also involve the plastic surgeon for it may require flap or reconstruction.
Okay, anyone else? Who did this report?
Radiologist.
Okay, and this report?
Which one? Histopathology department.
Yes, pathologist. That means pathologist. So radiologist, pathologist, plastic surgeon or general surgeon, and also oncologist. Okay?
Yeah.
Okay, now the patient has breast erythema and discharge present. What test to do?
Then I'll take the sample and send it swab and send it for culture and sensitivity.
And what will be the organism?
Staphylococcus aureus.
And can you tell me the treatment?
Yeah, if the patient is inpatient, I'll start IV antibiotics, and antibiotics will be IV vancomycin, or according to mostly they are sensitive to vancomycin, or I'll chase the report also, and also I'll take some preventive measures, like if the patient should be isolated, and hand hygiene, and there will be single like the nurse, whoever comes in the contact with the patient, he should wash hands, wear gown, gloves while touching the patient, and also involve the ID team.
Okay, very good. But Dr. Pooja, don't tell the antibiotics name directly. You have to tell in your exam like this, that I will give the patient antibiotics according to local trust policy, because different countries have different policies. Okay, we don't know in
Okay.
which country which antibiotic will work. Okay, so at first you have to tell that I will give the patient antibiotic according to local trust policy, and if the examiner will ask what type of antibiotic or name some antibiotic, okay, then after that you tell the rest. Okay.
Okay.
Okay. Now, would you please tell me, the patient has erythema around the nipple, what will be the DD?
It can be dermatitis, or it can be Paget disease also.
Paget's disease also. Okay, very good. Now, Dr. Ahmad,
Yes.
can you tell me the pathophysiology of Paget's disease?
But okay, it's a ductal carcinoma inside that invading the nipple outwards. I really cannot remember this.
Nah, that's all. You have told the answer. Okay, Dr. Pooja, continue, no problem. Can you tell more?
Okay. Yeah, in the basis of ducts, there is proliferation, there are epithelial cells, and these epithelial cells, they travel through the ducts to the skin, and there they cause, that's why there is and then they cause irritation. Therefore there is erythema, and there is sepsis.
Okay, thank you, Pooja. So, Dr. Ahmad, what is the action of radiotherapy in bone metastatic breast cancer?
The action of radiotherapy.
Yes.
Okay, it has a direct action of the cancer cell by damaging the DNA, promoting cell death, and indirect action by releasing reactive oxygen species.
Very good. Now, Dr. Ahmad, can you tell me this question's answer? What Pooja missed? This one, number 6. One microscopic test to do before LD flap.
I have no idea. This one is totally new for me.
This is new
But
for you.
yes.
Okay. Okay, that's all. Okay, these questions are end. So the answer of this question will be, what one microscopic test to do before LD flap? This is just MRCS screen. Okay, we just take the sample and send it for microbiology test. Okay.
Also
And
screen. Okay.
That I told
yes,
that I will send it for culture and sensitivity.
culture sensitivity. Yes, MRCS screen. I told you that. What would you be please more specific? Okay, so it should be like MRCS
Okay.
screen. Okay, MRCS
Okay.
screen. Definitely, you should send the sample for microbiology and culture, but for which MRCS screening. Okay, and what if it
Okay.
become positive? Dr. Ahmad, can you tell me if the patient got MRSA positive, then what will be the treatment options?
If he is carrier or infected. If he is carrier, I will give him, according to, after having a discussion with a microbiologist and according to the local trust policy, I will give him, if he is a nasal carrier, I will give him mupirocin, chlorhexidine for his skin. Or he is infected, I will give him vancomycin, IV vancomycin. And of course, stop the operation.
Okay. Okay. Pooja, can you tell me more specifically? Like what will be the duration of this treatment? What Ahmad said?
I think it would be 4 to 6 weeks.
No, not 4 to 6 weeks. What will be the, 2% mucin in nose? Okay, so what will be the duration in case of this
It's
treatment?
5 days for skin, and for chlorhexidine and for mucorsin, it's 5 days.
Yes, yes. And how many times in a day?
I think chlorhexidine is once daily, and
Yes,
mucorsin is 2 to 3 times a day.
3 times a day. Okay,
Yeah.
okay,
And for antibiotics, it's 2 weeks.
okay,
Yeah, now I remember.
okay. Very good, Dr. Pooja and Dr. Ahmad. Thank you so much for your participation, guys. So let's see some
Thank you.
questions of breast carcinoma. Okay. So what Pooja missed in this question? What have to look for in pathological report? Okay. K167 proliferation index. Okay. Pooja, you missed it. Okay. No
Okay.
problem. Let's remember something. Okay. See, assume that this is a tumor. Okay. And what we have to look for in pathological report, keep this picture in mind, okay, in your exam like this, that we have to find out what type of tumor is this, and in case of margin, see what will be its margin status, and also what will be the distance lymphovascular status. Okay, so we get 3 points here. What will be the type of tumor, what will be the lymphovascular status, and what will be the margin status. And you can see there are 2 receptors here. Okay, one is HER2 receptor. If it is positive, indicate poor prognosis, and if the ER or PR receptor positive, which indicates good prognosis. Okay, and we also do K167 index, which indicates the progression of the tumor. Okay, so these 5 things we will look into the pathological report. Now, what is HER? It's an oncogene biomarker, human epidermal growth factor receptor 2 protein, which is overexpressed in 15% of the breast cancer. And what are the tests we have done to find out it? One is immunohistochemistry, and another one is fluorescent in situ hybridization. What we measure by immunohistochemistry, we measure the amount of protein, and by FISH, FISH technique, we measure the number of copy of gene. So one is the amount of protein, and the another one is number of copy of gene. Okay. Now, what does it signify? Okay, if the HER positive become positive, it indicates that the tumor has bad prognosis, rapid spread, grow faster, come back, and also it is hormone insensitive. Okay, now next, role of radiotherapy in bone metastatic breast cancer. Dr. Ahmad told it nicely. Just for you again, I have shown the slide. Okay, so radiotherapy contains ionizing radiation that kills the osteoclast and tumor cells. As a result, there will be reduction of tumor volume and also protect the adjacent nerve from compression. So what does it result? See, eventually it prevent pathological fracture and spinal cord compression. Okay, so this is how radiotherapy acts in case of bone metastatic breast cancer. So thank you all for participating this mock. Thank you, everyone. Do you have any questions on this 5 topics? I think Dr. Jaiti, are you there? I think you have some questions. You sent me a message. Dr. Jaiti, are you there? Dr. Jaiti, are you there? Okay, no problem. So again, thank you all guys. I just want to tell you that we have a mock only course and it will be started on 1st July. Okay, 2 months course. And if you want more information, please visit our Telegram and Facebook group MRCS Insights, and you can knock us in this WhatsApp number. Okay, that's great. Thank you very much, everyone. See you in next mock, and I wish you all the best. Okay.
Finally, I became a millionaire again. Jesus, poverty, I cost you.